Good morning, everybody. Today we are going to discuss anatomy of the kidney part second. This session is for phase first and phase 4 students. Learning objectives for my today's class are: at the end of this session, students should be able to define renal angle and know its clinical importance. They should be able to understand anatomical basis of nephroptosis, enumerate and describe various congenital anomalies of the kidney. They should know anatomy of transplanted kidney. They should be able to read a KUB IVP, and also a USG film of kidney. They should be able to draw Morris parallelogram for surface marking of kidney. What is renal angle? Angle between lower border of 12th rib and lateral border of erector supini muscle constitutes renal angle. So this angle lies between the lower border of 12th rib and outer border of erector supini muscle as shown in this diagram. Clinical importance of renal angle. Renal pain is felt at renal angle as dull ache. Renal angle is site of swelling and tenderness in case of perinephric abscess. Lower border of pleura runs horizontally, crossing the 12th rib at the lateral margin of the erector supini muscle. Hence, upper end of incision for approaching kidney by lumbar root should begin below the renal angle. Otherwise, the pleura is in danger of injury if incision is extended above the renal angle. What is nephroptosis? Nephroptosis is also called floating kidney. Exact cause of nephroptosis is not known. May be congenital. Sudden loss of weight is an important factor for development of nephroptosis. Due to sudden weight loss, the supports of the kidney, that is perinephric fat, is lost, leading to this condition. In this case, only renal vessels form support of such kidney, usually asymptomatic in 90% of the cases. It is more common in females than males. In nephroptosis, kidney descent is greater than 5 centimeters on standing. Descent up to 2 centimeters is considered normal. Abnormal descent causes kinking of ureter and urinary obstruction. What is anatomical difference between simple and radical nephrectomy? In simple nephrectomy, we remove the kidney from within perinephric fascia. It is usually done in benign diseases of the kidney, whereas in radical nephrectomy, which is done in malignancies of the kidney, we remove the entire contents of the perirenal space, including perirenal fascia, in order to give adequate clearance around the tumor. What do you know about a transplanted kidney? What are the indications for kidney transplantation? End-stage renal disease is the common indication for renal transplantation. Left kidney from donor is preferred as its vein is longer. It is kept within the peritoneal cavity. Usually, transplanted kidney is kept in right iliac fossa. Its water is anastomosed with common iliac artery and its vein drains into common iliac vein. Now identify various anatomical structures in this wet specimen. The arrow represents left renal vein. This arrow represents right ureter. As you know, this arrow represents abdominal aorta. This arrow represents left gonadal vein. Left testicular vein drains into the left renal vein, whereas the right gonadal vein drains directly into inferior vena cava. And this arrow represents left adrenal vein, which drains into the left renal vein. Left renal crosses from left to right to end in inferior vena cava, whereas the right suprarenal vein drains directly into inferior vena cava. How is surface marking of the kidney done? The outline of both kidneys are mapped in Morris parallelogram that are drawn on the back as follows. 2 points are marked at a level of 11th thoracic supine, situated 2.5 centimeters and 9 centimeters from midline. 2 more points are marked at the level of 3rd lumbar supine, same distance away from midline. The 4 points are joined to form a parallelogram and the outline of the kidney is drawn on each side. The medial border of kidney is represented by a line joining 3 points. First, 2.5 centimeters away from the midline at the level of T11 on the left and the T12 on right. Second point at the level of L1 5 centimeters away, and third point at the level of L3 7.5 centimeters away from midline. Joining the first and third points at a distance of 4.5 centimeters from the medial border marks the convex lateral border of the kidney. As shown in this diagram, how to draw Morris parallelogram. Morris parallelogram is drawn by taking 1 point 2.5 centimeter at the level of T11 and another point 0.9 centimeters at the same level from T11. 2 more points are taken 2.5 centimeters and 9 centimeters at the level of L3. For joining these 4 points, we get a parallelogram called Morris parallelogram. Middle border of the kidney is drawn by taking a point TL at the level of T11 2.5 centimeters from midline. Another point is drawn at the level of L1, 5 centimeters from the supine of L1, and third point is taken at the level of L3, 7.5 centimeters from L3. By joining these 3 points, we get the medial border of kidney. Lateral border of the kidney is drawn by taking a point 4.5 centimeters from the medial border. What is a KUB X-ray? It is a plain AP supine radiograph of abdomen to assess the organs and structures of urinary and or gastrointestinal tract. K stands for kidney, U for ureters, and B for bladder. In addition to these structures, we can also visualize source shadow or outline in KUB. This X-ray is taken by keeping patient in supine position. Indications for KUB are: it is used for diagnosis of suspected stone disease such as calculi, which may be renal, ureteric, or in the bladder; to be a control film in anticipation of the contrast administration; to assess the presence of residual contrast from a previous imaging procedure after treatment of stone disease to look for the residual stones. It is also used for the diagnosis of congenital anomalies such as ectopic kidney, horseshoe kidney, and renal agenesis. It is also used to assess the position of stent drainage. It is also used as an adjuvant to investigation of blunt or penetrating trauma to the urinary tract. What are various anatomical structures seen on KUB? And the various anatomical structures seen on KUB are: kidney, we observe size, shape, position, axis, and orientation of the kidney. Natural contrast between the kidneys and the low density retroperitoneal fat that surrounds them means that they are often visible on X-ray of the abdomen. They lie at the level of T12 to L3 and lateral to psoas muscle. The right kidney is usually slightly lower than the left due to the position of liver. The size of the kidney varies with the size and sex of patient. An average renal length is equal to 3 to 4 vertebral bodies. The average length of left kidney is approximately 0.5 centimeters greater than that of right kidney. Position of the kidney. Normal position of the kidney, they lie at the level of T12 and L3. Right kidney lies at the level of L1 to L3, and left kidney lies at the level of T12 to L3 or L4. In this diagram, these red lines represent the psoas shadow. Superior lateral to the psoas shadow, there is right kidney. On the left side, superior lateral to the psoas shadow is left kidney. As shown in this X-ray, we can see kidney and psoas shadows. In searching for a ureteric stone on plain radiograph of the abdomen, one must imagine the course of ureter in relation to the bony skeleton. It lies along the tips of transverse process, crosses the front of the sacroiliac joint, swings out to the ischial supine, and then passes medially to the bladder. An opaque shadow along this line is suspicious of calculus. The course of ureter is readily studied by examining a radiograph showing a radio-opaque ureteric catheter in situ. The ureter is divided into 3 sections. What are the 3 sections of the ureter? Ureter is divided into upper third from renal pelvis to the top edge of the sacrum, middle third from top edge to the lower edge of the sacrum, distal third lower edge of the sacrum to urinary bladder, as shown in this diagram. Constructions of the ureter. Ureter has got 3 constructions. First, at the beginning, that is at the level of pelvic ureteric junction. Second, at pelvic brim where it crosses external iliac artery. Third, at vesico ureteric junction just before it enters in the bladder. Clinical importance of these constructions. These constructions are situs for stool formation or impaction. Bladder on abdominal X-ray. The bladder has variable appearance depending on how full it is. It has the same density as other soft tissue structures due to its water content. On KUB, we can also see the psoas shadow, which lies on either side of the lumbar vertebral column, below and medial to psoas muscle. KUB, we can also see the outline of psoas muscle. This muscle lies on either side of the lumbar vertebral column, below and medial to kidney. It gives psoas shadow on KUB, which is obliterated in enlarged kidney, psoas abscess, and splenic injury. What is intravenous pyelography or IVP? Most frequently employed radiological investigation of the renal drainage. The contrast material is administered intravenously. Urogram is visualization of kidney parenchyma, calcium, and pelvis resulting from IV injection of contrast medium. Pyelogram describes retrograde studies visualizing only the collecting system. So IVP is a misnomer, should be IVU, intravenous urography, rather than intravenous pyelography. It is also called excretion urography. This term is commonly used nowadays. Indication is for IVP to see the anatomy and physiology of the urinary system, to evaluate a patient after trauma. It's also done for renal, ureteric, and bladder calculi. By using IVP, we can diagnose horseshoe-shaped kidney and renal agencies. Other indications are infective pathology, renal tumor, unknown hematuria, renal hypertension, bladder pathology like diverticula, fistula, and vesico-ureteric reflex. Limitations of IVP. It depends on the kidney function. It does not differentiate solid or cystic lesion. It requires contrast medium and radiation. It misses small stones. Quality of study may be limited by inadequate bowel preparation, bowel ileus, swallowed air, and technician variability. Contraindications for IUP are hypersensitivity to iodinated contrast media, renal insufficiency, hepatorenal syndrome, thyrotoxicosis, and pregnancy. How it is performed. During intravenous pyelogram, a dye called contrast material is injected into the vein in the patient's arm. A series of X-ray pictures is then taken at timed intervals. The test should be done in X-ray department where a doctor is available as on occasions the contrast can cause severe reactions which may lead to medical emergencies. What is the preparation required for procedure? The patient may need to be fasting for 8 to 12 hours before the intravenous pyelogram. The patient also may need to take a laxative the evening before the test and possibly have an enema the morning of the test to make sure that the bowels are empty. Contrast material used in IVP is low osmolar contrast material. In adults, dose is 50 to 100 ml. IVP is done in a phased manner. The phases of IVP are immediate, that is called nephrogram phase, 5 minutes after injection of the dye, secretory phase, 15 minutes film with compression producing calcial distension. Then a film taken at 30 minutes after injection of dye is called ureterogram phase. Film taken at 45 minutes is called cystogram phase. Then post-widening film. Preliminary film is also called the control film. Immediate film is taken about 10 to 14 seconds after injection of the dye. This time represents the arm kidney time. The aim of this film is to show the nephrogram, that is renal parenchyma opacified by contrast medium in renal tubules. 5 to 15 minutes film is called a secretory phase. An AP film is taken to determine if excretion is symmetrical and is invaluable for assessing the need to modify the technique. For example, further injection of contrast medium if there has been poor initial opacification. 30 minutes film is called ureterogram. This film is taken to see if there is any collecting system and ureter dilatation or filling defect. Normal ureter filling is rarely demonstrate the whole ureter form proximal to distal as there is a peristaltic wave. 45 minutes film is also called cystogram film. In this film we see bladder size, shape, contrast is filling the bladder or not. Bladder surface is smooth or rough. Is there any diverticula, filling defect or indentation? Post-widening film is used to see the residual urine. Contrast left on upper tract normally where there is no contrast left on the upper urinary tract on post-widening film. Now let us try to identify these pathologies or congenital anatomies, how they look on KUB or on IVP. Identify the pathology in this X-ray. It's a KUB showing pyeloureteric junction obstruction as dilatation of the right renal pelvis and calyces. Identify the pathology. Again, pyelogram showing dilatation of left renal pelvis and calyces of both the obstructing calculus. Identify this pathology. Again, an IVP. On the right side, there is absent left kidney, and on the left side, is absent right kidney. Now, what is the single kidney? Absent one kidney seen in 1 in 1200 individuals results from failure of nephroblastoma to join with ureteric bud on affected site. There are no clinical sequelae, frequently be associated with absence of ipsilateral vas deferens and or epididymis. This condition may be associated with other congenital anomalies including imperforate NS, cardiac valvular anomalies, and esophageal atresia. A single kidney often shows compensated hypertrophy. It is important to note that the life expectancy of individual with a single kidney is the same as those with two kidneys. Now identify this anomaly. This pyelogram represents the pelvic kidney. What is pelvic kidney? Failure of kidney to ascend in utero to the correct position in renal fossa results in renal ectopia. Most commonly, the kidney is found in the pelvis. Its incidence is 1 in 2,500 live births. Kidneys so placed often have associated malrotation anomalies and may have marked fetal ablation. Pelvic kidney frequently becomes hydronephrotic as a result of an anterior placed ureter and an anomalous arterial supply. An associated pelvic ureteric junction obstruction is often present. Identify the pathology. This pyelogram represents renal collecting system and ureters crossed renal ectopia on the left kidney, absent right kidney. Now, what is crossed renal ectopia? When kidney is located on the side opposite that in which the ureter inserts in the bladder, the condition is known as crossed ectopia. 90% of crossed ectopic kidneys are fused to their epicycletal mate. A solitary crossed renal ectopia may be associated with skeletal and other genitourinary anomalies. As shown in this diagram, B represents crossed renal ectopia without fusion, C represents solitary crossed renal ectopia, and D represents bilateral crossed renal ectopia. Identify anomaly. This is an OIP demonstrating horseshoe-shaped kidney. On IVP, we can see flower vase appearance. Now, what is a horseshoe-shaped kidney? Incidence of horseshoe-shaped kidney is 1 in 400 individuals. A transverse bridge of renal tissue called the isthmus, which usually but not invariably contains functional renal substance, connects the two renal masses. The isthmus lies between the inferior poles, most commonly anterior to the great vessel. The ureters curve anterior to the connection and may have a high insertion into the renal pelvis. The blood supply to the horseshoe kidney is variable. One vessel to each moiety is seen in 30% of horseshoe kidneys. Multiple anomalous vessels are common, and the isthmus may be supplied by a vessel directly from aorta or from branches of inferior mesenteric, common iliac or external iliac arteries. In view of this variable arterial anatomy, angiography is very helpful when planning renal surgery on horseshoe-shaped kidney. What are the various associations of the horseshoe-shaped kidney? Horseshoe-shaped kidney is associated with pelvic ureteric junction obstruction in up to 30% of the cases. Anomalous vessels crossing the ureter, abnormal course of the ureters as it passes over the renal substance may also cause obstruction. Horseshoe-shaped kidneys have an increased incidence of stone disease, probably as a consequence of areas of inefficient drainage. Identify the pathologies. Represent as an IVP demonstrating the characteristic stretching of the calyces in cysts in polycystic kidney. This pattern is called supine leg appearance. Identify the anomaly. Here we can see duplex ureters on IVP. What is a duplex ureter? Also called duplicative collecting system. Here two ureters come out from a single kidney. These two ureters can drain independently into the bladder or connect and drain as a single ureter into bladder. Duplex ureter can occur in one or both kidneys. Identify the pathology. Left mega ureter on IVP showing dilatation of the entire length of ureter. Identify the pathology. Benign prostatic hyperplasia. White shadow represents the bladder. Dark represents the BHP, that is benign enlargement of prostate. What is the role of ultrasound in kidney anatomy? Ultrasound is a non-invasive scanning procedure based on piezoelectric effect. It is used for scanning kidney. In this figure, you see the USG lab in the Department of Anatomy at Government Medical College, Srinagar. How does ultrasound work? Ultrasound is based on the piezoelectric effect, where a transducer converts electric signals into the sound waves. These sound waves, after reflecting back, are picked up by the CPU, converted into an image which appears on the monitor. This image can be either stored in the computer or it can be printed out. We can compare ultrasound with the histology. So depending on the direction of the probe, we can take longitudinal section of a tissue. So in this section, these waves they pass through the liver and kidney in a longitudinal direction. Thus we get a longitudinal image of the kidney. Using this image, we can measure the length of kidney. We can also see the division of kidney into cortex and medulla. Now if we change the direction of the probe at right angles, now these sonographic waves they pass transversely through the kidney. We can measure anterior posterior diameter or transverse diameter of the kidney as shown in this diagram. Now let us go to this part 1. What does it represent? Identify viscera labeled as A, B. What is the length of B? A represents the right lobe of the liver. B represents right kidney. The average length of kidney on ultrasonography is 9 to 12 centimeters. So part number 2. Identify A is again right lobe of the liver. B is right kidney. Between A and B is C. C is basically hepatorenal pouch of Morrison. This pouch is a potential space. Normally there is no fluid collection between liver and kidney. but in case of effusion due to any pathology, this space gets filled with fluid which we can demonstrate on ultrasonography as shown by these yellow arrows. Dimensions of the kidney. As already said, dimensions of human organs vary in living and in cadaveric state. In living state, we can take dimensions of the kidney using an ultrasound, and these dimensions are: length of the kidney is 9 to 12 centimeters, breadth is 4 to 6 centimeters, and anterior posterior diameter is 3.5 centimeters. In contrast, in cadaver, the dimensions are: length 11 centimeters, breadth 6 centimeters, and anterior posterior diameter 3 centimeters. Weight of the kidney in men is 150 grams, and in women it is 135 grams. Now, what is hydronephrosis? Hydronephrosis is defined as a distension of the renal calyces and pelvis with urine as a result of obstruction of the outflow of urine distal to the renal pelvis. Analogously, hydroureter is defined as dilatation of the ureter. Hydronephrosis is classified into grades from 0 to 4 depending upon dilatation of renal pelvis and calyces. Grade 0, no dilatation. Calyceal walls are opposed to each other. Grade 1, mild dilatation of the renal pelvis without dilatation of calyces. Grade 2, dilatation of the renal pelvis, mild, and calyces, pelvic calyceal pattern is retained. No parenchymal atrophy. Grade 3, moderate, moderate dilatation of renal pelvis and calyces, blunting of the fornices and flattening of papillae. Mild cortical thinning may be seen in grade 3 hydronephrosis. Grade 4 hydronephrosis, also called severe hydronephrosis, there is gross dilatation of the renal pelvis and calyces which appear ballooned. Renal atrophy is seen as cortical thinning. Renal atrophy is seen as cortical thinning. Now let us go for a quiz based on this lecture. You will be provided an MCQ with 4 options. You have to find the most accurate one. Our first question is: which of the following is false statement about renal angle? It is bounded by lower border of 12th rib. B. It is not related to pleura. C. Renal pain is localized there. D. It is bounded by outer border of the erector supine. B is wrong option. Which of the following is a complication associated with pelvic kidney? Hydronephrosis, obstructed labor, hydroureter, hernia. D is the wrong option. The average length of the kidney shown by ultrasound in centimeters is: this question is based on the sonographic anatomy of the kidney. A 9 to 12 centimeters, B 8 to 12 centimeters, C 6 to 9 centimeters, D 7 to 10 centimeters. A is the correct option. Which of the following is not a cause of nephroptosis? A. Congenital, B. Weight loss, C. Tuberculosis, D. Trauma. And D is the wrong option. Which of the following is not an association of unilateral renal agencies? A. Imperforate anus, B. Short lifespan, C. Contralateral absence of vas, D. Esophageal atresia. B is the wrong option. Which of the following is not associated with horseshoe-shaped kidney? Absence of seminal vesicle, B. Pelvic-uterine junction obstruction, C. Compression of ureter by anomalous vessels, D. Increased incidence of stone disease. A is wrong option. Which of the following is not true about vascular supply of horseshoe-shaped kidney? A. The blood supply to the horseshoe kidney is variable. B. One vessel to each moiety is seen in 30% of the kidney. C. Isthmus may be supplied by a vessel directly from aorta. D. Isthmus may be supplied from branches of superior mesenteric, common iliac, or external iliac artery. D is the wrong option. Superior mesenteric artery does not supply horseshoe-shaped kidney. False statement about nephroptosis is: it is also called floating kidney. B. Exact cause of nephroptosis is not known. C. It is caused by sudden weight loss. D. More common in males. D is the wrong option. False statement about nephroptosis is: kidney descent is greater than 5 centimeters on standing. B. Up to 2 centimeter descent is considered normal. C. It causes kinking of ureter and urinary obstruction. D. Renal vessels and ureter form kidney support in nephroptosis. D is the wrong option. Which of the following is not a contraindication for IVP? Impaired renal function test, B. Thyrotoxicosis, C. Diabetes mellitus, D. Drug allergy. C is the wrong option. It is complicated diabetes mellitus that is a contraindication. Secretory phase of nephrogram is taken after how many minutes of dye injection? 2, 3, 5, 10. Correct option is C, after 5 minutes of dye injection. Thank you for watching this video. Do not forget to subscribe this channel. Press on the bell icon to remain updated.